Okay, chapter 32, which is multi-systems trauma. This is just kind of a catch-all chapter, not a very long chapter at all, but it's kind of a catch-all chapter to help us kind of pull some of this trauma stuff together. We're really kind of pulling into the end of the trauma section here, but sometimes we have patients with broken bones and they're bleeding and they're in shock and they have a head injury and they have an abdominal injury because they've been thrown out of the window of their car going 85 miles an hour down the highway. And so that makes the patient a multi-system trauma. The more systems you involve, the generally worse off you do. So there's just a couple of quick objectives listed on 791. So multimedia videos, one that kind of walks you through gunshot wounds, multi-system injuries to front-end collisions, and multi-system injuries in vehicle collisions in general. Core concepts are how to balance the critical trauma patient's need for prompt transport against the time needed to treat all the patient's injuries at the scene. So this is kind of a scene management chapter. How to determine the severity of the trauma patient's condition, their priority transport, and their appropriate transport decision. How to select the critical interventions to implement at the scene versus for a multi-system trauma or a multi-trauma patient, and then how to calculate a trauma score. So multi-systems trauma. What can we tell from this video or from this picture? Well, it's hard to say. So from initial glance, it looks like he has a gunshot wound to the leg. In most cases, we wouldn't suspect that somebody with a gunshot wound to the leg probably would be unconscious, but he certainly appears unconscious. So we have to continue to assess what's going on here. If we take a look at his arm, we note that there's blood on his arm. That blood doesn't seem to really jive much with that blood that's come from his leg. So maybe he has been beaten and shot or stabbed or whatever he's got going on with his leg. And those are defensive wounds. So hard to say from first look, so we have to obviously dig a little deeper. So a multi-system trauma patient is a patient with one or more injuries serious enough to affect more than one body system. So like I mentioned, we may have patients with head and neck and chest trauma. Might have somebody who's bleeding. Might have somebody who's been bleeding and burned and has fractures. So things that we use to determine their severity, number one, physiologic criteria. So what are we seeing when we start to look at the picture here? What do we see as far as signs or symptoms? So do we have things like altered mental status? Do we have hypotension, abnormally slow respiratory rate, normally high respiratory rate? So those are some signs or symptoms that kind of go along with, this isn't normal. So what's going on here? So that in and of itself may not be much, but when we start to couple it with other things such as anatomic criteria, so injury to specific body part requiring immediate surgical intervention. So if you've got a head, neck, chest wound, head, chest, abdomen wound, you probably are going to need surgery fairly quickly. Multiple musculoskeletal injuries. When you break one bone, it's bad, but when you bring multiple bones, you start to really confuse the system, you lose a lot of stability, and you've really started to insult the system. Amputations. So if you have an amputation, that's obviously pretty severe in many cases, as long as it's anything beyond the wrist or the ankle. Severely mangled extremities, pelvic injuries. A lot of these things have obviously showed that there's been high energy and the patient's probably undergone a significant shock or trauma to their system. Then, of course, mechanism. So in the absence of the anatomic or physiologic signs, MOI is considered if severe. Falls, high-risk auto crashes, auto pedestrians, cycle crashes, those all have the potential to be high index of suspicion mechanisms. So to manage our trauma patients, first of all, practice with your crew and determine what the roles are going to be. We can't have people jumping all over. If there's 4 people on a call, 4 people answering questions or asking questions, the patient gets confused. Well, if people don't get on a task and do their task and stick to doing what they're supposed to be doing, a lot of times they'll jump ship and start doing somebody else's job. And then we're not being efficient in the way that we need to manage our patients. So en route to the call, have everybody kind of step up and say what they'll do. Obviously, scene safety is paramount. There's a lot of dangers involved with traumas. We've got unsafe terrain to be on. We've got vehicles, hot fluids. We may have electricity. We may have broken metal and glass. Could be dangerous people or animals in the area. Might be an unsafe environment. Penetrating trauma, are they still around the scene? Auto crashes, we've always got looky-loos that want to see what's going on. They're not paying attention to you because they want to see what's going on with the car. So follow our priorities to determine determined by primary assessment. So we look for those life threats and we attend to those. If patients have life threats, those of course get the brunt of the majority of our attention. Reassess what to treat on scene and what needs definitive care. Call the hospital, let them know so they can be prepared, potentially even call for a helicopter. Anyone can request a helicopter. Now remember, helicopters aren't all that people initially believe they are. They save you time if you can get them, if the helicopter can land on scene and fly the patient out that otherwise wouldn't be able to get going much quicker. So a long extrication. You show up at an auto accident, the patient's already been ejected or extricated from the vehicle, and the helicopter is 20 minutes out and you're 10 minutes from the hospital. You're a moron if you sit around and wait. Get the patient to somebody who can do something. The helicopter can meet him at the hospital, and maybe the doc will come out to the ambulance and say, I really don't want to do anything with them, just put them on the helicopter and send them away. But if you're sitting around with the patient that nobody is doing anything with, that patient's losing valid or precious time. So we don't sit around waiting for helicopters, but if the helicopter can be there at about the same time that we'll have the patient ready to go, then that's appropriate. Attend to life threats, reassess what to treat on scene and what needs definitive care. So we're talking about broken bones. We have a whole body splint. It's called their backboard or your long spine board. We don't need to put 14 splints on this patient when we can just do it all with a backboard, get them on the way to the hospital. We'll deal with the individual little things later. So when we're treating, make sure that we're keeping people in the loop, make sure we stay up to date on what's going on with our patients. Limit our scene treatment. Things that we're going to do on scene: airway, initial airway stuff, suctioning, cleaning it out, putting in oral or nasals, getting the patent airway, manual stabilization of the C-spine, opening the airway, ventilating, oxygen, bleeding control, and immobilizing. That's the multi-system trauma treatment. That's about the extent of it. Of course, if you need to do CPR and AED, of course that fits in there. That's kind of an extenuating circumstance. But even paramedics are not supposed to sit there on scene starting IVs on patients. They're supposed to do that on the way to the hospital. Expect the unexpected. Adapt to the situation. We're good at that in EMS. That's what we do. Do what's necessary to make sure you maintain ABCs. If you need to do urgent or emergency moves, do those. Sometimes we have to alter what we've initially been taught because we hear that most patients, to be safely removed from a vehicle, we're going to use a vest-style extrication device unless they show immediate signs or symptoms that they're deteriorating. Well, that's all good and fine. We may have a conscious patient that's been involved in an accident, but yet it's 40 degree below zero wind chills on the top of a hill with very little protection, and it's raining and snowing. That changes things. we now say we're going to endanger this patient by sitting here on scene and by not doing something to protect him or her. So those are cases in which we then will kind of change up the treatment plan simply for the fact that it's in the best interest of our patient. If a patient's body part isn't accessible, assess what you can. So trauma score is a numerical rating system for trauma that assigns a number to patients with certain characteristics and creates a certain score. Objectively describes the severity, and it helps determine transport to a trauma center or a local hospital, and it helps trauma centers evaluate the care of similar patients. So it's kind of a standard. So there's the revised trauma score, which uses 3 major components: the Glasgow-Coma scale, which we all have already learned about, the systolic blood pressure, and the respiratory rate. And then we're going to follow our local protocol for using that system. Don't let it interfere with patient care. I got to tell you what, the trauma score really doesn't mean a whole heck of a lot to most people. Yes, they use it in the trauma centers, but in reality, it just is taking away precious time that most of us could be doing something else. And again, like the Glasgow-Coma scale, there's too many potential ways that this system can be flawed. So the things that we're going to look at for the revised trauma score: Glasgow-Coma scale, systolic blood pressure, and then the respiratory rate. And then if you wanted to look at a quick look there, you can look at the revised trauma score criteria as far as if their GCS is less than 14 or less, blood pressure is less than 90 systolic, and the respirators are less than 10 or greater than 29. That's enough suggestion that this is a severe injury, and this is something that needs to be treated and transported immediately. If you want to see the official breakdown of the revised trauma score, you can look at page 801 in your text, and that revised trauma score shows you that if your Glasgow-Coma scale is within such and such and such and such, you get 4, 3, 2, 1, 0 points. Systolic blood pressure greater than 89 is good. Less than 70, it's between 76 and 89 is 3, so on and so forth. And then it goes on to talk about respirators as well. You can develop, add those up and come up with a sum. Max is going to be 12, minimum is going to be 0, which differs from your Glasgow-Coma scale, remember, which is a max of 15 and a minimum of 3. And there it is. Okay, so you got a video on a couple of different types of injuries here. And in review, multisystem trauma is a serious condition in which multiple body systems are injured or affected. Recognizing multisystem trauma, triaging appropriately, and transporting promptly to the correct destination are vital for the survival of your patient. The CDC has issued guidelines for trauma triage and transport. Usually these have been reinforced by the state. Iowa does have a Iowa triage and transport protocol. It needs to be used in conjunction with your local protocols, because in reality, well, not everybody's 20 minutes from a level 1 trauma center. It would be nice if everybody was within 20 minutes of a level 1 trauma center. It's just not practical. All right, so things to remember. Your primary assessment should determine whether your patient is seriously injured or potentially seriously injured. Limit your scene time. Try to use a platinum 10 minutes if at all possible. Get them loaded and going. Our golden hour begins at the time of the injury, not at the time we get there. So things to keep in mind when you're assessing your trauma patient. Is my patient seriously injured or potentially seriously injured? Should I expedite? And what is the most appropriate transport destination for my patient? Is it the local hospital, or is it the one that's 5 minutes further that has better trauma services? So our critical thinking question is, a patient is involved in a car crash with significant intrusion into the area in which the patient is sitting, or the patient compartment. Intrusion means that a lot of the car has moved into that area. So the patient is alert and complains of pain in the ribs. Pulse is 96 and regular. Respirators are 30 and adequate. Blood pressure 100/62. Pupils are equal and reactive. Skin is cool and dry. Your partner says the patient is stable and could easily be transported to a community hospital nearby. You think the patient should be transported to a trauma center. How would you justify your decision to your partner? So how do we justify this? Well, let's take a look back again. Significant intrusion into the area of the car where the patient is sitting. So there's a high-risk mechanism. Patient's alert, complain of pain in the ribs. There's the potential there for there to be rib fractures that would lead to respiratory issues. Heart rate is a little high. It's still within normal, but obviously showing some problems. Respirators of 30. 30 is way too high. So in this case, I think you can honestly say that it's suggestive that there may be trauma to the chest area that is involving his respiratory drive. Blood pressure 100/62. In most cases, that would be considered to be a low blood pressure. In a skin that is cool and dry, depending on the situation, patient maybe should be warm. But if they're dry, it at least is speaking something for him. So you could say that there's probably chest trauma involved here. It's hard to assess the remainder of what potentially could have gone wrong without seeing the patient or seeing the vehicle. And with the potential for the chest trauma, there's the potential for the respiratory trauma.